Thank you very much. Very good morning to all of you. So, without much delay, let's get started with the blood gas analysis. Unfortunately, these days we are running our ICU without a single blood gas for many days, but blood gas blood gas analysis is very important in the management of any critically ill patient, right? So this is a picture of a blood gas, right? So you can see that it gives you many information. It's a huge bank of information. It not only just tells about how your blood is, but it's talk about how your lungs are working, whether your kidneys are working fine, whether your heart is doing its job. So it's a multi-systemic analysis, right? And it's a very quick bedside test, very easy to perform. And blood gas analysis is actually simple. But of course, you can go into very complex analysis as well. But I was given the task to tell you how to analyze this in a simple way. So we will be focusing on this. Right. So what are the information you can gather from a blood gas? Right. As I mentioned you before, it tells us about the adequacy of oxygenation, how well the arterial blood is oxygenated, and also the adequacy of ventilation, how well we clear our carbon dioxide. And it tells us how to determine the acid-base status of our body, and also it gives some other clues to identify what is the abnormality that we have. So it gives the electrolytes, lactate, hemoglobin, blood sugars, these things, right? So this is a blood gas analyzer. You must have seen this machine. So you feed some arterial or venous blood, which is heparinized, and it gives certain values which are actually measured in this analyzer. PaO2, carbon dioxide, pH, electrolytes, lactate are the values it directly measures, and bicarbonate, SaO2, that is arterial oxygen saturation, and base excess are the values it calculates using various nomograms and formulae. So before starting to analyze, you should know the desired values of these blood gas values that it gives. So pH roughly 7.4, 35 to 45, 7.35 to 45. Arterial oxygen partial pressure should be roughly around 80 to 100. Carbon dioxide partial pressure should be around 40, so 35 to 45 is fine. Bicarbonate 22 to 26. Arterial oxygen saturation 95 to 100. Base excess plus or minus 2, and lactate should be less than 2. So just remember these values for the time being, because we are going to analyze several blood gases. So if you are given a blood gas, you should go in a stepwise manner to analyze a blood gas. First of all, if you have a blood gas, just think about the patient, how my patient gather some information. Then evaluate the oxygenation, then go for acid-base status, and then look for other clues. So I will give you this blood gas, right? So it has given several values. Now you are going to interpret this arterial blood gas, right? So now you need to know about the patient, right? So what do you want to know? History and examination findings, whether the patient is on oxygen or not. If so, what is the fraction of oxygen patient is on? Whether the patient is spontaneously breathing or is he mechanically ventilated? And of course, whether it is an arterial sample or a venous sample. So the blood gas that I gave you belongs to a 40-year-old gentleman who was admitted following a road traffic accident 3 hours back. And he has chest and lower limb injuries. He is conscious, his heart rate is 120, so his tachycardic, blood pressure is low, 90 by 60, and he is tachypneic, and he is given 60% oxygen via a Venturi mask. And you are given this arterial blood sample for analysis, right? So remember this history when you analyze the blood gas. Now, the second step is evaluation of oxygenation, right? One value that you can gather from the blood gases is the arterial oxygen partial pressure. If we are breathing room air, it will be around 80 to 100. But if some supplemental oxygen is given, there will be more oxygen in our alveoli, and hence our arteries will extract more and more oxygen. So the arterial partial pressure of oxygen will be more than this normal value. How would you know what the expected oxygen level if a patient is given supplemental oxygen? There are several formulas. So one simple one is this expected PaO2 equals to the FiO2 into 500. If the FiO2 is given as a fraction, if a patient is breathing normal air, fraction of oxygen is 0.21. So you multiply it by 500. So it will be around 100. Now, our patient is given more oxygen, so we expect more oxygen to be dissolved in the blood. So, this is the calculation that we are going to use for analysis of our patient's blood sample. The other thing that we can use is the PF ratio, that is the ratio between the arterial partial pressure of oxygen and the FiO2. So, if someone is breathing room air again, 100 divided by 0.21, it will be roughly equal to 450. But if a patient has a PF ratio of less than 300, that patient has some oxygenation failure. There is some problem in the patient's oxygenation. Then SaO2, that is the arterial oxygen saturation. How much of hemoglobin is saturated with oxygen? It is just like the SpO2, the plethysmography value that we look for. So it's around 95 to 100. And some blood gas values give you the AA gradient. If it gives you AA gradient, roughly remember 5 to 15 is roughly a normal value, but you need to do some calculations, but I'm not going to go into details about that. Right. So what about our patient? So this is the blood gas I gave you. PaO2 is 98. So it's in the normal range. So there is no hypoxemia. Patient's oxygen level is okay. SaO2 is 96. So that is also fine. So there is no hypoxemia in this patient. But what's the problem? Our patient was given 60% oxygen. So according to our calculations, we expect the patient's PaO2 to be around 300. But it is 98. What about the PF ratio? The PF ratio is 98 divided by 0.663. It's less than 300. So there is a significant oxygenation failure. There is an oxygenation failure, but because we have given oxygen, there is no hypoxemia according to the blood gas value. Right? Okay. Now, what about a venous sample? That is when we are given an arterial sample. So, you can understand that for us to get details about oxygenation, we need an arterial sample because all these takes the PaO2. But how do you know whether your blood gas is a venous sample or an arterial sample? You simply look at the patient's saturation, plethysmography saturation, and check whether it is more or less equal to the saturation that is calculated by the blood gas, right? If it is a venous sample, the SA saturation will be around 70 to 75 and PaO2 will be around 35 to 40. Other than oxygenation, the other values can be taken for pH values, acid-base calculations, just as the arterial blood sample. pH will be little less, carbon dioxide will be little high, about 4 to 5 millimeters mercury, but otherwise it can be used for normal acid-base disturbances and analysis. Right, now we are going to move to our third step, which is to evaluate the acid-base status, right? Again, I'm going to give you this stepwise approach. So first look at the pH and see whether there is an acidemia or alkalemia. Then look at the primary acid-base abnormality. Then see whether there is a compensation and whether it's adequate. And if there is a metabolic acidosis, try to calculate the anion gap and see what type of a metabolic acidosis that is. Just to recap some basic physiology, our body is constantly producing lot of acids, right? These acids can be categorized into two, with volatile acids and non-volatile acids. Carbon dioxide, which can be easily eliminated by the lungs, it's a volatile acid, and the other acids like lactic acid, sulfuric acid, phosphoric acid, all these things are non-volatile acids, which are mainly metabolized by the kidney, excreted and handled by the kidney, right? So if you want to look at a blood gas, and we all know there are two components of acidosis, whether it is coming from the volatile acids, if it is so it's coming from the respiratory system, and if it's non-volatile, it's a metabolic component, right? So if you want to know about the metabolic component, you will look at the bicarbonate and the base excess value in the blood gas. If you want to look at the respiratory component of your acid-base status, you look at the carbon dioxide value. And this simply summarizes the pH regulation in our body. Let's say there is addition of some acid into our body system, right? So when acids are added, the first line rescuer that comes is the buffers, right? The most abundant buffer in our body system is bicarbonate. So H pluses will react with the bicarbonate and it will produce more and more carbon dioxide. Then after about few minutes, the lungs will take over this buffering activity of getting the pH back to normal, and the respiratory rate will increase and it will try to eliminate the carbon dioxide and get the pH back to normal. After about few days, the kidneys also start to work and will work in its maximum capacity in about 3 to 5 days. It will try to reserve more and more bicarbonate and eliminate the H pluses. So likewise, there is this nice balance in our body to buffer or compensate if there is any acidosis or alkalosis. Right. Because I mentioned about the base excess, I'll just tell you what base excess is. So it's actually, there are some bases in excess. Because of that, the pH is now alkalotic. So what this value means is the amount of strong acid that has to be added to 1 liter of fully oxygenated blood to return its pH back to normal. And this is a calculated value. So it assumes that the temperature is 37 and the carbon dioxide is 40. So if a patient is alkalotic, the base excess is positive. That is to say, you need to add acids. But if a patient is acidotic, there is no excess of bases, but there is a base deficit, right? So it will give you a negative value. Right. So coming back to our stepwise approach to analyze the blood gas. So step 1 is to see whether there is acidemia or alkalemia. So acidemia is just like hyperkalemia or hypernatremia. There is more hypernatremia, more sodium in our blood. Likewise, more acids in our blood is called acidemia. So if the pH is less than 7.35, it is an acidemia. If it's more than 7.45, it's an alkalemia. But we are not using these two terms very commonly. We rather use alkalosis and acidosis. But actually, what acidosis is the process which can lead to acidemia. And alkalosis is a process which can lead to alkalemia, right? So when we look at our blood gas, we see that the pH is 7.3. It's less than 7.35. So it's acidemia. Step 1 completed, right? Step 2. What is the primary abnormality? So here we are going to see why the pH has changed. Now the pH is 7.3. There is an acidemia. What caused this acidemia? We want to know whether it is because of the carbon dioxide or because of some metabolic derangement. So if we want to see about the respiratory component, we look at the carbon dioxide. If you want to look at the metabolic component, we look at the bicarbonate or base excess. Right? So let's go to this table. So first one, the pH is 7.3. So there is acidemia. What explains this acidemia? Carbon dioxide has gone up. Bicarbonate has gone up. If the bicarbonate goes up, it doesn't cause acidemia. But if carbon dioxide goes up, it causes acidemia. So the primary disorder is respiratory. So it's a respiratory acidosis that has caused acidemia. Next one. Again there is acidemia. But here the bicarbonate has gone down and the carbon dioxide is also low. Low carbon dioxide will cause alkalosis and low bicarbonate will cause acidosis. So this acidemia is explained by the bicarbonate. So it's a metabolic alkalosis which has caused acidemia, metabolic acidosis, which has caused acidemia. Next one, pH 7.5. So there is alkalemia, and what has caused the alkalemia is low carbon dioxide. So it's a respiratory alkalemia. Next one, there is alkalemia, and it is caused by a high bicarbonate. So it's a metabolic alkalemia. Here you see that the values in red has caused the primary abnormality, but the other value that is given in brown color is also not normal. That has also changed. That change is that change is there because it is trying to compensate for the primary acid base abnormality. If we take the first one, because the pH is acidic, the kidney is trying to retake more and more bicarbonate and trying to compensate for the acidemia caused by the respiratory acidosis. And so we are going to see whether this compensation is adequate in our third step. So actually there are two, I would say there are two methods. Like you just can simply look at the pH and see whether the compensation is adequate. But if you want to more accurately go into details, there are specific calculations that you can use for different abnormalities and see whether the compensation is adequate. And you have to remember that there is never an overcompensation. But to make it simple, to cover blood gas analysis in 30 to 40 minutes, I'm going to talk about looking at compensation by only looking at the pH. Right? So again, there is acidemia. It is caused by the respiratory component. Why the bicarbonate has gone up is because it's trying to compensate. But even though it is trying to compensate, still the pH has not come to normal level. So it is trying to compensate, but it has not fully compensated. So it's a partially compensated respiratory acidosis which has caused acidemia. Next one, there is acidemia, but it's more or less normal. It's just close to the normal level, right? The primary reason is respiratory, but here the compensation mechanisms are working nicely that the pH is brought back to near normal. So you can say it's a compensated respiratory acidosis. Next one, there is acidemia. It is caused by the metabolic component and they are trying to reduce the carbon dioxide. Normally is 40, now it's 35, but the pH has not yet come to normal, so it's partially compensated. Next one, pH is normal actually, but carbon dioxide is low and the bicarbonate is again low. The pH value is towards the acidic side, so there is a metabolic acidosis which is now nicely compensated with the respiratory component. Right? Next one, alkalemia. It is due to respiratory component and because pH is still high, it's partially compensated. Right? Right. So that is the simplest way of identifying whether it's compensated or not. But I told you there are several calculations for various metabolic abnormalities and to considering whether it's an acute abnormality and chronic abnormalities, there are certain formula and these formulae can be used if you know the primary abnormality, but I'm not going to talk about this and complicate you further, right? So we are going to go into our patient's blood gas analysis. So you can see there is acidemia and there is metabolic acidosis, that is the primary problem. Bicarbonate is low, there is a base deficit, that is why base excess is minus and it's partially compensated. When it comes to partially compensated, you are a little worried why the body could not completely compensate this blood gas abnormality. We expect the respiratory system to work nicely and eliminate more and more carbon dioxide and get the pH back to normal. But we are now in a situation that there is only a partial compensation. We are now thinking whether there is some respiratory problem as well. Is that why the patient has not partially compensated, right? So that is some idea that you can get even without using hi-fi calculations. Even by just looking at the pH, you can come to this diagnosis. Right. Next step is to see what type of a metabolic acidosis the patient has. So our patient has metabolic acidosis. So you go and calculate the anion gap. Why you calculate the anion gap is to identify the cause. According to the anion gap, the acidosis can be divided into three. It's high anion gap or normal anion gap or low anion gap metabolic acidosis. Right? Right. So what is this anion gap? Right? It is just a hypothetical value because we are not, our body is not a charged body. Our anions and cations are in a balance. But here what we look at is the difference between the measured cations and the measured anions. So anion gap can be calculated by taking the sodium value, chloride and the bicarbonate value. So you simply deduct the chloride and the bicarbonate value from sodium value, and the normal is roughly 10 to 40. So this graph shows you in a graphical way what the anion gap is. Now this gap of anions are non-measured anions, which can be like phosphates, sulfates and proteins, right? And because protein is also, especially albumin is an anion, if the albumin is critically low, we have to actually correct this value for the low albumin, but I am not going to go into details about that calculation, right? So we are going to our patient. So we already know that our patient has a metabolic acidosis which is partially compensated. So we are going to measure the anion gap. Anion gap, sodium 144 minus chloride 110 and the bicarbonate 14. So the value is 20. So our patient has a high anion gap metabolic acidosis. So what? So if we know that our patient has a high anion gap metabolic acidosis, there are certain causes which causes the high anion gap metabolic acidosis, which is given in the mnemonic mud piles, right? So this list of causes can cause high anion gap metabolic acidosis. As you can see in the diagram, the first one shows the normal anion gap. In high anion gap metabolic acidosis, what actually has happened is, let's say the patient has ketoacidosis, so there are more keto acids in our body. The H pluses will get buffered with the bicarbonate, so the bicarbonate level drops, and the anion, if it is acetoacetone, those anions, if it is formic acid, formate, these anions accumulate even though the H plus is buffered by the bicarbonate, so the anion gap increases. So what are the causes for normal anion gap metabolic acidosis? As the diagram shows, the third one shows that the anion gap remains normal, but this patient has a loss of bicarbonate, and that is compensated by accumulating more and more chloride by the renal system. So their anion gap remains normal even though the bicarbonate is low. So if you infuse a lot of sodium chloride infusions, the hypernatremic hypochloremic acidosis and acetosolamide, especially GI causes diarrhea and profuse vomiting and fistulae can cause this type of acidosis. Low anion gap metabolic acidosis is really, really rare. That occurs especially in circumstances where the unmeasured cations are high, right? These are few examples for that, right? So we are now in our fourth step. We are now going to look at the other parameters of the blood gas. One important parameter is lactate, right? So lactate is produced by the pyruvate, especially when there is cellular hypoxia. So if there is low hemoglobin, low oxygen, if the perfusion is poor, the cells are going to be hypoxic, so there is anaerobic metabolism. So pyruvate will be converted to lactate, and lactate will accumulate. And other than that, metformin toxicity, and if there is hepatic failure, there will be high lactate production as well. And you also have to look at the electrolytes, hemoglobin, blood sugars, and these values which the blood gas machine will calculate for you. Now we are coming back to our patient, right? So our patients, what are the other parameters our blood gas shows? we can see that lactate has gone up. Lactate is 4.8. There is lactic acidosis, and that may be the reason why the patient's anion gap has gone up. And we can also see that the hemoglobin is low, 6.3. What else? The potassium value is 5.6. There's hyperkalemia, and the sugar value is normal. Right? So if we have only this, if we forget about the patient, if we look at this blood gas, so there is partially compensated metabolic acidosis and HB is low, there's hyperkalemia, it doesn't give much value. But what if you combine the blood gas value with your patient? Now, your patient is coming after a trauma. He has chest and lower limb injuries. He's tachypneic, tachycardic, and his blood pressure is low, and he is given oxygen. Now, this patient has partially compensated high anion gap metabolic acidosis with acute respiratory failure. Their lactic acidosis. Why there is lactic acidosis? That may be because of the poor perfusion conditions. HB is critically low and perfusion is affected, blood pressure is low. So there is cellular hypoxia which is producing acids, and that is why the patient's pH has deranged. And HB is 6.3. So this is a trauma victim. The patient is bleeding. HB has dropped to 3. So it is alerting you. So you have to find the cause for the bleeding and attend to that. And hyperkalemia. It's not just hyperkalemia, it shows. It may be because of the acidosis, there are potassium coming out of the cells and causing acidosis. There may be muscle patient has lower limb injury. There may be muscle injury and rhabdomyolysis. Potassiums are released from the muscle cells. And because of the low blood pressure and because of the rhabdomyolysis, maybe the patient's kidneys are also affected, and it is also contributing to this acidosis. So, with this patient information and that blood gas value, you can go for a better treatment. The patient needs blood transfusion, correction of blood pressure, and look for signs of bleeding and stop bleeding. Correct the hyperkalemia, otherwise it's going to go for arrhythmias and stuff. And you need to look for acute kidney injury now. You need to screen for the rhabdomyolysis. And will you give bicarbonate to this patient? Because the patient has acidosis and the bicarbonate is low, why not give some bicarbonate and correct this acid-base abnormality? That is quite a simple measure that you can do. But why this blood gas is abnormal? That is because of these problems. That is because of poor perfusion. Without correcting the cause, there is no point in giving bicarbonate. You are just trying to correct the pH only. And not only that, giving bicarbonate unnecessary will have other consequences as well. It is going to increase the cellular acidosis. It is going to increase the sodium levels, so many problems, right? So you're not going to correct the bicarbonate value, but you're going to correct this patient, treat this patient and correct the abnormalities, which will bring the pH back to normal, right? So this is just a summary of what we learned. And if a patient has respiratory acidosis, the patient is retaining carbon dioxide. So the patient's ventilation is affected. Starting from the respiratory center, nerves and the rib cage, the respiratory muscles, diaphragm, all those things can cause ventilation problems and increase in carbon dioxide. If a patient has respiratory alkalosis, that is to say patient is breathing at a rate. So think causes like anxiety will cause such a picture. Metabolic acidosis, we know with the high anion gap, normal anion gap causes which cause metabolic acidosis, and metabolic alkalosis is mainly because of gaining of either bicarbonate or you are losing H+, especially in gastric vomiting. So we will analyze another blood gas, right? So you are given this blood gas, you are going to analyze this. And what's the first step? You need to know about the patient, right? Okay, this is the history. This is a 68-year-old gentleman, known history of CKD. He has gone into a cardiac arrest and the patient is resuscitated for 10 minutes and arterial blood gas was done. And this is it. Right. Now what is the next step? We are going to analyze the oxygenation, right? Now this patient after cardiac arrest, so he is ambu ventilated, right? So roughly with an ambu bag, with the reservoir bag, you can give up to 90% oxygen. So expected PaO2 is 0.98 to 500. So you are expecting a PaO2 of 450. But the patient's PaO2 is 90. So there is, even though there is no hypoxemia as such, because it's between 80 to 100, these can be considered normal. There is no acute hypoxemia, but there is a significant respiratory problem, significant oxygenation problem. What's the PF ratio? 90 divided by 0.9, 100. There is, again, it is showing us it's less than 300. There is significant oxygenation failure. So this is a patient with CKD gone into a cardiac arrest. So the lungs are not doing fine. Maybe the patient went into an AKI, pulmonary edema, and had a cardiac arrest, or during the cardiac arrest, maybe the patient got aspirated and the lungs are affected. So many reasons. Right. Then we are going to do the acid-base analysis. pH, there is acidemia. Yeah. What explains this acidemia? Now the PCO2 has also gone up. So it also explains acidemia. And the bicarbonate is also less than 24. It's 12. So that also explains the acidemia. So this patient has mixed respiratory and metabolic acidosis, which has caused a significant acidemia. So there's no compensation, of course, because both systems are not working fine. Then, because there is a metabolic component, we are going to look at the anion gap. Anion gap is 22. There is a significant anion gap. So he has a high anion gap metabolic acidosis. Other parameters, high lactate, 5.8. So the patient with the cardiac arrest, definitely there is tissue hypoperfusion. So it has caused a high lactate level. So lactate may be one reason for the high anion gap metabolic acidosis. Then carbon dioxide is also high, so there's hypoventilation. The person who is doing hypoventilation need to do more, need to get this get out of this carbon dioxide. And there is hyperkalemia. What does that say? Maybe the acidosis has caused this potassium to come out, or with the history we know that the patient has CKD, maybe he went into an renal failure and hyperkalemia may be the reason for the cardiac arrest, right? So blood sugar is high, we don't know that maybe the patient is diabetic or just with the stress response, the sugar can go up. Right? So with the history and the blood gas, it gives quite a lot of information about the management of patient. So what would you do? You will mechanically ventilate this patient. This is a post-cardiac arrest patient. You need to correct the patient's oxygenation and ventilation. There is significant oxygenation failure for which you might have to get rid of the fluid. If it's pulmonary edema, so give furosemide, PEEP, or you might have to dialyze and get rid of the fluid. And you have to correct the hyperkalemia, correct the hemodynamics. You might have to start inotropes and get the patient's blood pressure back to normal and correct the hypoperfusion. Now, in this situation, would you give bicarbonate? Yeah, we don't like bicarbonate, of course, that is true, but their situation here is little different. Now, this patient has critical acidosis. His pH is less than 7.15. And on top of that, there is hyperkalemia, which has caused the cardiac arrest. And also, the patient's heart is not really working. That is why the patient has gone into a cardiac arrest. The blood pressure might be significantly low after the resuscitation. So here, to overcome this negative inotropy caused by the acidosis, you can give some bicarbonate. The dose can be calculated with the use of base excess into 0.3 into body weight, and you can roughly give about half of that to correct this severe acidosis, severe critical acidosis, to get the heart to work fine. But of course, you have to correct these problems as well, right? So this gives some indications for bicarbonate treatment in metabolic acidosis. If the bicarbonate is less than 4, you will give in critical acidemia, and negative inotropy you can give, and also in normal anion gap metabolic acidosis you can give, because there is loss of bicarbonate there, right? Right, okay. Now, I'm not going to talk much detail about this, but in actual life, we know that the acid-base derangements are quite significant, especially when it comes to complex patients. So we do not really know which way to go, this way or that way, right? So for that, for an example, I'm going to give you this case. This is a patient with long-standing COPD, and also he has stage 4 CKD. He is coming with 5-day history of vomiting and diarrhea. He is dehydrated and blood pressure is quite low. Lactate is 3.8. So what are the acid-base derangement that this gentleman can have? He has long-standing COPD. So there is a possibility of chronic carbon dioxide retention and chronic respiratory acidosis. Stage 4 CKD, there is metabolic acidosis caused by the renal problem, and the patient has vomiting. If it's mainly a gastric vomiting, there is loss of H pluses, so it can cause metabolic alkalosis. And the patient has diarrhea also, so there is loss of bicarbonate, which can cause normal anion gap metabolic acidosis. And the patient's blood pressure is low, perfusion is low, lactate is high, so that can cause high anion gap metabolic acidosis. So patients can have mix of everything. So you sometimes will have to use those complex calculations that I showed you for different type of abnormality. There are different calculations. There is this delta gap that is coming into play. There is something called delta ratio, delta gap. All these can help us to analyze blood gas into greater detail, but I'm not going to complicate you with these things. But that is also possible. Right. So it's 12:15. I will just show one example of this complex calculation, and then I'm going to go for a little game. Right. So this is a patient with 56-year-old gentleman with pneumonia and septic shock. The important details are given there. So primary problem is a metabolic acidosis, and you can see it's partially compensated. I told you that there are several formulae. One is Winter's formula that is specifically made for metabolic acidosis. That gives you how to calculate the expected drop in carbon dioxide to compensate this pH. According to this calculation, we expect the carbon dioxide to drop to 26 to compensate the pH back to normal. But this patient's carbon dioxide has not dropped to 26, but still, even though it has dropped, it's still high, 33. So this patient has both metabolic acidosis and respiratory acidosis, and both of those have caused the anaesthesia, right? So to our patient, if we apply this formula, we know that there is, with simple calculations, we know our patient had a metabolic acidosis which was partially compensated. With that, we assume that there can be a problem in the respiratory system. So by using this formula again, we expect the carbon dioxide to drop to 29, but carbon dioxide is 31, and that is the very reason why the patient has not compensated. And we have got the same inference. Even with the simple analysis, we knew that there is a problem with the respiratory system. Even with these hi-fi calculations, we are. Oh, right. Okay. It is finished. Let me make it a little like that.
You are now muted. You are now unmuted.
Sorry for that. So we are now going to play a small game. Sorry for that. So we are going to play a small game. I would like. I would like if you can join to Kahoot.it with your mobile phone. Either you can play individually, or one or two of you can get together and work as a team, because I have only the free version of Kahoot and it only allows 10 people to join at a given time. So if two of you can join and connect with one single device, that's fine. So have you all gone to the Kahoot.it? It's not Kahoot.com, it's Kahoot.it. Right, so it will ask you to enter a game pin when this loads. Now this is the game pin that you have to enter. Enter your name or a nickname or whatever. The 50,000 cash will be coming from the KSA president if you win. Right, there's space for another one. It's telling me that there are 13 participants, but usually the free version allows only 10 participants, but we'll see. Right. Right, you can select the answer from your phone. This is question number 1. Select the answer and enter the answer from your phone. 24-year-old boy with acute opioid intoxication. The blood gas is given. Select the correct answer. More seconds left. Right, 14 correct answers, so I have done something good. Right, so it's an uncompensated respiratory acidosis because the bicarbonate was normal. So Nilanka, you are first, or Nilanka. Next question. 13-year-old girl presents with DKA, and you have to select the wrong statement here. Wrong statement. Pretty easy. Answers are coming up. 8, 9. You have only 4 seconds left. wrong statement is that the patient needs bicarbonate. No, we are going to treat the patients with fluid and correcting the sugars, right? Okay. Still the majority is have given the correct answer, so I'm still doing good. ABC is now leading. Question number 3. It's a true false answer. The respiratory system is the first line rescuer in an acute acid-base stage in our body. Is it the first line rescuer? Right! It's the buffer's first line and then the respiratory system. ABC, you are doing great. Next question. 56-year-old male is admitted with a 4-day history of diarrhea. Is tachypneic and dehydrated? Select the correct answer. You have 12, 11, 10 seconds. Great, well done. MW. Right. Next one is true false question. Regarding the same patient, whether that patient has a high anion gap metabolic acidosis. True or false? Super. Well done. Right. Sixth question, one before the last. ABG of a patient with ARDS is given below. He is on 60% oxygen. Select the correct statement. For this, I have given you 1 minute. Is it the correct answer you got? 7, you have given the correct answer. Right, the last. MW. You are leading. The last question. Vitals of a patient is given. Respiratory rate 35. Heart rate, blood pressure and saturation is 90. It's simply asking whether this is an arterial or venous sample. Great, well done. So the saturation is 94, its saturation is 75. Right. So let's see who the winners are. Anu has got the third place. Congratulations, Anu. And Nima, you are in second place. And is it MW? Yes. You are the first place winner. Can I see these three people? Anu, Hima and MW. You are? Hima. Well done, Hima. And Anu. Well done. And Chirinti, MW. Well done. I hope you learned and enjoy about the arterial blood gas analysis. Any questions? Any questions? No? Then we'll sum up. Thank you very much then.